in-depth exploration of the world of women today with Sandra Elkin.
Good evening and welcome to Woman. Our topic tonight is unnecessary surgery. With me to discuss this is Barabra Ehrenreich, co-author with Diedre English of two widely circulated pamphlets, Witches, Midwives, and Nurses, and Complaints and Disorders, The Sexual Politics of Sickness. Barabra is also co-author of The American Health Empire, Power, Profits, and Politics. Also with me is Barbara Seaman, author of Free and Female and the Doctor's Case Against the Pill. Barbara was recently identified by the Library of Congress as the first author to raise sexism in healthcare as a worldwide feminist issue. Welcome to both of you. How much unnecessary surgery is there in the United States today?
It's estimated that 1 in 6 operations is unnecessary, that there are about 12 million operations performed annually, and 2 million of those are on perfectly healthy organs.
Well, is anyone concerned about this?
I am.
Are you?
I would add that an estimated at least 10,000 people a year die from those unnecessary operations every year. So somebody ought to be concerned.
The something in our culture, for some reason, surgery has been sold to us like used cars. Our most widely read national magazine has at least one article a month that science writers jokingly call New Hope for the Dead articles, and always promoting some wonderful new procedure that's going to save a lot of lives, and of course people rush out and ask for it. Somebody recently did a study where they went back and looked at all the wonderful medical advances that were promoted in those articles, and they found that something like only 7% of them had actually panned out. But people not only rush to have surgery, they even rush to have experimental surgery. Apparently they don't know that once you go under general anesthesia, your chances of never waking up are 1 in 1,500. In addition to that, speaking of the anesthesia effects, there are others who are left permanently crippled from the anesthesia. If, for example, the supply of oxygen to the brain is cut off for a few minutes, it can leave you quite brain damaged.
So really what you're saying is that the general public is really not aware of the problem.
They seem to think surgery is fun.
Oh.
Well,
I don't think you can really blame the public, though, because it's ultimately the physician, the surgeon, who decides whether it's going to be done to you or not. And he, I use the pronoun advisedly, he is the one access to that surgery. And it's the doctors who write the articles in the National Enquirer, or who are interviewed for the National Enquirer and the other magazines, telling about the wonderful new treatments they have. So they do their own advertising, and then they determine who's going to have it done to them.
Mm-hmm.
You said in our culture. Now, that implies that it's different other places.
Well, in England, for example, there's only about half as much surgery. There are only about half as many surgeons. And yet the life expectancy and general health of the people is certainly as good. In England, there is no fee for service for doctors. They're sort of on salary, and then they do a lot of consulting before a surgeon does an operation. He discusses it with specialists in other areas who try to see if there are milder treatments that might be applied first. And I think that in our country there's a shortage of general practitioners and of internists. These two fields are the guardians against unnecessary surgery. And so a lot of people just go to a surgeon, even as their main physician. For example, gynecology is actually a surgical specialty. And, you know, if you're trained to be, even if you're very well-intentioned, gynecologists are surgeons, and surgeons are like generals who are trained to fight, so they want to fight. So the surgeons are trained to operate, and they want to operate. I mean, what they think of first is a surgical solution, whereas a course of drugs or rest or various other alternatives might take care of the problem.
What are the kinds of surgery that are most prevalent that you
Diet.
think?
Like, look at all the ulcer surgery that's done on people whose condition could have been perfectly well controlled by diet. I mean, there are some very simple remedies that just aren't tried.
Well, list some of the kinds of surgery that are most commonly unnecessarily done.
According to one estimate, the top 3 are hysterectomies, tonsillectomies, and hemorrhoidectomies. And in fact, one doctor calls these remunerectomies. Incidentally, the estimate that I was referring to is a very valuable booklet that I'd like to recommend. It was written by Herbert Dennenberg, who was the health commissioner for the state of Pennsylvania. And it's called A Shopper's Guide to Surgery. And it's available for $1 from Consumer Insurance, 813 National Press Building, Washington, D.C.
We can repeat
viewers-
that later on in the program. Barbara, do you think that there's more unnecessary surgery done on women than on men?
Well, I can tell you one figure which makes me certainly be suspicious in that way. A recent study by two physicians revealed that 55% of the hysterectomies performed in the hospitals they were studying were unnecessary, whereas the figure for prostatectomies was 9%. So that's an amazing difference. And Barbara Seaman gave the figure before for all kinds of surgery. The rate is around 15% for all kinds of surgery, 15% unnecessary. And if it's 55% for hysterectomy, which is something that men don't have, it certainly looks like there's a kind of a sexual bias there.
So really, in a sense, we're talking mostly about gynecology, aren't we, when we're talking about unnecessary surgery for women?
Well, no, there are a lot of unnecessary tonsillectomies, hemorrhoidectomies, appendectomies. One problem is that only about half of the surgeons in this country are fully qualified. That is, only about half are diplomats of, have their boards, are board certified in surgery, and are also fellows of the American College of Surgeons. And also, only about 2/3 of the hospitals are fully accredited. Now, even the standards for accreditation of hospitals are not actually that high, so it doesn't even mean that much to be accredited, but it means a little something. So if you get one of the 50% of doctors who isn't very well trained operating at a hospital that has virtually no standards, it's no wonder that some of those hospitals are called butcher shops, because that's what they are. And there are, according to one estimate, Howard and Martha Lewis wrote a very good book called The Medical Offenders, which was published in 1970. As of 1970, they estimated that there are about 15,000 doctors in this country who are really bad doctors, who really should not be practicing at all. And on one level, that doesn't sound like so much, except that one bad doctor can mutilate hundreds of patients a year. And we naively believe that the doctors are policing themselves, but they're really not. That is to say, the surgeons who belong to the American College of Surgery and so on are meeting high standards, but when half of them aren't even meeting those standards, it's a very dangerous situation for the consumer. All you have to do to call yourself a surgeon is to be medically licensed in that state. You don't even have to have had a month of actual surgical training. And lots of people who do months of research before they buy a car or a refrigerator are just willing to hop up on a table and let anyone who calls himself a surgeon cut into their belly. It's really an amazing thing.
I think we have to talk about some of the ways to avoid this. I mean, what are some of the things that the individual medical consumer can do to prevent this? Barbara?
Well, I really am sort of cynical at this point about how much the individual medical consumer can do. I think we can think of some suggestions between us, like getting a second opinion on anything. What I see, though, is that for so many of us, and I include myself in this category of consumers, it's hard to get another opinion. It's costly, especially if you're already in some form of, insured plan to go out of that or something else. It's also hard to know whether the second opinion is any better. Is more qualified. What are we going to do? Take a statistical poll of all the surgeons or gynecologists we can find? Ultimately, I think that we're going to have to move beyond that kind of individual self-defense and find ways that we as consumers can evaluate and monitor our medical services And I think that most of the energy for that is going to come from women because we're the big victims.
And we're starting to do that. In some cities, the women's health groups are monitoring the doctors and medical services in the community and doing a good job, too. They're collecting patients' reports and so on. But in the meantime, I do feel that there are a number of points. They're discussed in the Shopper's Guide to Surgery pamphlet that I mentioned, but there are certain minimal things a person can do.
Mention some.
Okay, first of all, one should never have a surgeon as their main doctor, and I include gynecologists among the surgeons.
Why is that?
Because they think of surgery as the first instead of last, since that's what they're trained to do. And their intentions may be good, but they don't keep up on alternatives and less dangerous methods of treatment as well as an internist or a family practitioner does. So I don't think anybody should ever agree to have an operation without having an internist or family practitioner, a real family doctor type, in on the case and consulting closely with the surgeon. Secondly, no surgery should ever be agreed to without getting at least one other opinion from another surgeon as well as the family doctor. Now, I'm not talking about having a wart removed, but any surgery that requires going under general anesthesia, for example. Just remember the figure I gave before, that there's a 1 in 1,500 chance that you'll never wake up if you contract to go under general anesthesia. So that should be enough to make you want to shop very, very carefully. Then thirdly, make sure that the surgeon you go to is board certified and a fellow of the American College of Surgeons. Now, there might be some exceptions to that. There are some surgeons who are very competent who somehow haven't gotten all their formal training, but you're most apt to find them in rural areas and places like that. And if the person has an excellent, excellent local reputation and you know that other doctors they're sending, for example, are sending their families to him, then maybe you can overlook the fact that he's not board certified. But in general, unless you know him very well, I would check that he's board certified. You can usually look him up in a medical library or in a public library.
After someone is board certified, is there a period when they are re-examined, re-evaluated?
Some states are just starting to move into that. As of now, though, generally not. So even that isn't a guarantee, but it eliminates the people who've had no training at all. Then I think you should check out carefully on your anesthesiologist, because more and more, as a matter of fact, there are more malpractice cases against anesthesiologists than against any other specialists at the moment. And it's a very tricky surgery, it's a very tricky business, modern anesthesia, and you want to make sure that you have a highly competent anesthesiologist. Make sure that the hospital that you're going into is an accredited hospital. And if possible, I think it should be a hospital affiliated with a medical school. That is, if you're middle class, it should be a hospital affiliated with a medical school. If you're poor, I'm not so sure that that's true, because at some of these teaching hospitals, they do a lot of experimentation on the charity patients or the Medicaid patients. I don't know, what's your feeling about that?
It's very hard to get exact statistics on the numbers of unnecessary hysterectomies done on women in the wards of public hospitals or voluntary hospitals, because naturally the hospitals aren't going to tell you how many are unnecessary. But I'll give an example. An intern at one of New York City's public hospitals, which serves mainly black and Puerto Rican patients, noticed that the rate of hysterectomies appeared to vary with the season. He thought, that's interesting. It's not like colds that, you know, have a different rate with winter or summer or something. And so he checked it out and just found out that it was correlating with when they were teaching how to do hysterectomies. And then there were more, and it would go down when they switched to some other thing. So, you know, definitely a lot of this is going on in the, for poor women. They're very much at risk for this. And it's because hysterectomies are interesting to do. If a woman wants to be sterilized, the doctors would much rather do a hysterectomy, because that's a good thing to learn, and a tubal ligation, as I think one resident said, any monkey could do. So Fine.
It
And
does.
I think that's where probably the most serious, well, there's serious problems for the women who can pay, and she is a high candidate for surgical plunder because of her money, and for the woman who cannot pay, who is confined, who has no private doctor, who goes through the clinic, she is not going to be able to do the things you just listed, though, in her own defense.
I know.
Because she's presented with a group, the chiefs of service, right down to the lowliest interns, who've already agreed on what's going to happen to her. And that's where we have to begin to take some control of those institutions.
But I gather there
Barbara,
are...
excuse me.
Yeah.
Is there some historical precedent for the high rate of hysterectomies?
Well, I don't think that there's that I know of a precedent for hysterectomies, but gynecology and surgery, as Barbara mentioned, are so closely connected in their whole history in this country. Gynecology really got started as a specialty of surgery, and a lot of surgical advances were pioneered on women, especially, interestingly enough, black slaves who could be bought for the purposes of experimentation. But one of the big things in the 19th century, 100 years ago, was taking out women's ovaries. And that was done for the purpose of gaining psychological control over women. Physicians 100 years ago thought that if like you could make a bull more tame by castrating it, you could make a woman more tractable and passive and sweet by taking out her ovaries. See, perfect medical scientific reasoning there. So that became a real big thing 100 years ago and lasting into the 20th century, removing ovaries to calm women down, like if they were interested in women's suffrage or something. And the doctors would actually pass around at medical meetings these preserved ovaries that they had removed with pride. So that was a booming business 100 years ago. I don't know what's going on, but I think that, we can look at the profit motive to explain this unnecessary attacks on our organs. We can look at the need for doctors to learn to, how to do the procedure, so they do it on poor women. But it almost seems to me that there's like a psychological dimension too, that physicians have seen the female body as some kind of dark frontier that they have to master, conquer, take things out of. I don't know.
So you're saying that it's not a social function, medicine is not serving a social function as a service organization, but it's a control thing? Are you going to go that far?
Well, I don't know how much good medicine is doing for people's health in this country. When we look at the number of people who die because of medical care, I think we have to ask the question also, how many people are surviving today despite medical care? It's the connection between people's health and getting so-called high-quality medical care seems to be a little bit tenuous. So what is going on with it? I think one thing that's going on for women in medical care is that for most of us, it's an experience which sort of reinforces our feeling of being inferior. The whole medical theory of women's personality is that women are passive, masochistic, it means they love pain, so they should love these operations. Doctors reinforce this attitude in many ways in their encounters with us and in the kind of care they give us.
Illness is feminine, right? I mean, hasn't that always been a thing? Barbara, what were you going to say before? Do you remember?
No.
I'm sorry I interrupted you. Well, what do you
Barbara was telling us about historically was fascinating. Oh, I know. I wanted to ask Barbara, the Greeks, the word hysteria is derived from the word for wandering uterus.
Right.
And I think that even the ancient Greeks used to do hysterectomies to treat emotional illness, didn't they? Do you have any data on that?
I don't know if they could then do hysterectomies for sure, but there's always been a kind of male idea that if you want to control a woman's brain, you start down with her reproductive
pelvis,
organs, take some of them out or something like that.
Well, the reasons that women have hysterectomies, Barbara, you talk about that.
Well, a lot of women, in medical audits of hysterectomies, it has been found that not only are many of them done on perfectly healthy organs, but that the reasons given include things like backache, headache, depression, and I mean, some of them aren't even done for things like bleeding. There's just no remote justification at all, except that I have been told that there used to be kind of a sort of a, what's sometimes called a quiet conspiracy between Catholic doctors and Catholic women who had had a lot of children, that apparently now from recent surveys, most Catholic couples are using birth control. But until recently, that was not as clearly true. And sometimes if a woman felt that she just couldn't use birth control, but she was worn out from child rearing, her gynecologist, with good intentions, would cook up some excuse to do a hysterectomy so that she wouldn't be able to have more children. And
you made a very radical statement recently at a women's health conference in Boston.
mm-hmm.
And you said we should get men out of gynecology.
Yeah. I don't think that there's any legal way we can get them out altogether, but by using empathy tests and other things that are being done now with establishing, selecting people for human rights commissions and all that, I think we could return the field to women. And I do think it should be a women's field. I just wonder why they want to have their big hands in their vaginas. I mean, it's a little... it doesn't seem like a natural field for a fella to go into.
I don't think, I mean, I agree with you. I want the men out too. But I think that it won't solve all the problems we're talking about. Because there is this problem, for example, of unnecessary, as I mentioned, unnecessary surgery on poor women who are the, quote, teaching material for doctors. Now that's going to go on whether the doctors in training are male and female, unless we remove that two-class system that makes some people be teaching material and others not. And also, the association with of gynecology and surgery, has got to end too. I think we all agree on that. That gynecology has got to stop being seen as a place where you just exercise a scalpel.
Mm-hmm. Oh yes, and there's an enormous amount of unnecessary surgery short of hysterectomies on the female organs. It's felt that most D's and C's, or many D's and C's, are completely unnecessary. And cauterizations, if you consider that surgery, I don't know, is that...
Well, it's a serious enough procedure.
About half the cesarean sections performed appear to be unnecessary.
Well, for instance, if a woman has been told that she's going to have a cesarean section, I mean, how can she tell whether she needs one or not? Do either of you know the answer to that?
Well, again, I would suggest that she be in as good a hospital as possible, have a good family doctor looking over her shoulder, ask for a consultation. You can certainly reduce the risks of an unnecessary operation if you check out all those things. And then another thing that I forgot to mention before is that I feel that before anybody does any procedure to me that could in any way mutilate or maim or possibly even kill me, that he has an absolute obligation to describe what the alternatives are, what the risks are if I don't have the procedure done, what the possible outcome is if I try various other therapies, or what the outcome would be if I have no treatment at all. This is what we mean by the doctrine of informed consent.
Well, this has to do with the recent malpractice law in New York State, and I understand other states are considering the same kind of thing.
Yes, well,
do you want to explain what that is? I mean, until
yes,
it was.
as I'm sure everybody in the audience knows, there has been an enormous increase in lawsuits against doctors, malpractice suits. And it has reached crisis proportions, and malpractice insurance has skyrocketed. Now, there are various approaches to solving the problem. The approach that I would advocate, and that there are a number of doctors who advocate too, is that you stop overselling medicine, that you have a more informed public, and the more informed the public is, and the more they come to trust and know their doctor, that the less likely they'll be to sue. And they won't expect miracles. And then they won't be disappointed when they don't occur, and so on. However, another completely opposite approach to the crisis is to say a little knowledge is a dangerous thing, and we can reduce the suits if we don't tell the public anything. Now, a certain number of these malpractice suits, I think it's about 1 in 15, are actually based on the lack of informed consent. That is, the patient says, I would never submitted to that surgery on my spine or my shoulder to repair a minor athletic injury had I known that it might leave me permanently paralyzed, as it did. And the doctor never told me that, and that's the grounds on which the patient sues. So in order to curb that kind of suit, the New York State, the governor's malpractice bill, as it's called, has a provision that patients can no longer sue for informed consent unless the drug or surgical procedure was experimental. And of course, that's being fought very bitterly now by various consumer and feminist groups. The ACLU is trying to knock that provision out of the bill. But I do want to alert your viewers all over the country that probably in many other states, a similar provision is going to be slipped in. Many of the state legislatures now are working on new malpractice bills, and I'm sure a number of them are going to try to eliminate informed consent.
We don't have a lot of time left. We wanted to recommend some of the publications and so on that we know about that would give people more information if they want it. And of course, Barbara Ehrenreich's two books, one, Complaints and Disorders, the other being Witches, Midwives, and Nurses. And Barbara, you recommended this other book, which is not yours, but How to Avoid Unnecessary Surgery. You can leave a list with us.
It's by a male surgeon, yes, by the way. And I do want to say, that actually there are even some marvelous male gynecologists.
Why don't you leave a list with us, both of you, and we will be glad to pass it on to our audience. Also, Barbara Ehrenreich recommends Health Right, which is a newsletter. Yeah. What do you think, very fast, because we have about 15 seconds, is unnecessary surgery, do you think, the single most important thing facing women as far as a health issue is?
What do you think?
It's hard to rank them. I think attitudes of gynecologists is one. Cost of health care is probably one of the worst at this point.
I think birth control experimentation is very high.
Thank you both for being here. Thank you for watching, and good night.
Woman was produced by WNED-TV, which is solely responsible for its content, and was funded by public television stations, the Ford Foundation, and the Corporation for Public Broadcasting.